All right, today we're going to explore this topic that many psychiatric clinicians encounter in practice, but often are quick to maybe dismiss and get very little formal training, and it is likely the reason why. And we're going to talk about nutraceuticals, adaptogens, dietary supplements, specifically those used in mental health. Now, patients will routinely ask about supplements for anxiety and depression and sleep, attention and stress, and in many cases they are already taking them before they even ever see us. So the challenge is going to be to know that these products exist in a gray zone between nutrition, herbal medicine, and pharmacology. And some do have meaningful evidence behind them. Others are ineffective, and a few carry some real safety risks, especially when combined with psychotropic medication. So the goal of this session is not to promote or dismiss the supplement outright, but to offer an approach that through evidence-based clinical reasoning, you can hopefully speak intelligently to your patient, and you'll understand some of the mechanisms and recognize some of the potential interactions so that you can counsel them responsibly. So the goal is to help you move from opinion-based conversations about supplements to something that's clinically informed. So by the end of this lecture, there are several things I want you to be able to do. First, I want you to understand the regulatory and scientific landscape around nutraceuticals and supplements. Knowing how these products are classified and regulated will help you explain both their popularity and their limitations. Second, I want you to examine the mechanism and evidence behind several commonly used supplements in psychiatric care. And I want you to look at what the research actually shows rather than relying on social media and marketing claims. And then finally, we're going to discuss the safety considerations, including drug-supplement interactions, variability in product quality, and situations where supplements may worsen psychiatric symptoms. The broader goal is to equip you with enough clinical framework for evaluating supplements so that when a patient asks about them, as they inevitably will, you can respond thoughtfully and safely and with some professional confidence. One of the reasons this topic is so important is that supplement use is extremely common among patients with psychiatric symptoms. Many large surveys suggest that a substantial portion of adults are taking psychiatric medications or also using some form of a dietary supplement, often without informing the clinician. And patients may view these products as safer and more natural or more compatible with their personal beliefs about health. At the same time, the supplement industry operates under a very different regulatory framework than prescription medications. Products can reach the market without the level of evidence we expect from pharmaceuticals. And for the psychiatric provider, this kind of creates a dilemma. So if you ignore supplements, that leaves a gap in patient care. But if you accept them uncritically, that can expose the patient to ineffective treatments and interactions or delayed care, and so the task is going to be, how do you understand where these supplements fit into a broader model of psych treatment, and how do you evaluate them using the same scientific thinking we've been using all along that you apply to medications? Well, before we evaluate any supplement clinically, you need to first understand the regulatory landscape, because these products don't exist under the same standards of evidence. So at one end of the spectrum, you have dietary supplements, and these are marketed primarily for general wellness. And under U.S. law, they do not require FDA approval for safety or efficacy before they enter the market. It's the manufacturer that's responsible for their own product claims unless the FDA later identifies a problem. In the middle ground, we have these things called medical foods, and these are different. These are intended for the specific dietary management of disease and have to be used under medical supervision. These are not approved as drugs, but they are expected to be based on recognized scientific principles and a clinical rationale. And at the far end of the spectrum, you have pharmaceuticals, and these are the ones that undergo rigorous FDA evaluation for safety and efficacy before approval and are subject to strict manufacturing and labeling standards. The key takeaway here is a label claim is not the same as clinical evidence. So as a clinician, we have to be able to evaluate these products using peer-reviewed research rather than the marketing language. Now, medical foods occupy this special space in psychiatry because they're often marketed for neurological or psychological conditions. Now, under the regulatory framework established through this Orphan Drug Act and subsequent FDA guidance, medical foods must meet several specific criteria. First, there must be scientific justification. The formulation should be based on recognized nutritional science and medical evaluation. Second, the ingredients must meet safety standards typically described in the GRAS list. GRAS is generally regarded as safe by qualified experts. The third is the product must have a targeted composition. In other words, it's not just general nutrition. It's designed to provide specific nutrients that are missing, impaired, or required in higher amounts due to a disease process. And fourth, the product must be used under medical supervision. These are not meant to be casual, over-the-counter wellness products. Finally, in clinical practice, we need to document clearly when you're using these products, the indication, the product name, the dosage, and the monitoring plan to justify the medical rationale. Another way to think about nutraceuticals is through this concept of nutrient pharmacology. So traditional dietetics focuses on maintaining general health through balanced nutrition. Pharmacology, on the other hand, targets disease processes through medications designed to alter specific biological pathways. While nutrient pharmacology sits in this middle ground, it uses concentrated pharmaceutical-grade nutrients to influence metabolic pathways that are relevant to disease. So instead of simply asking whether a patient eats enough of a nutrient, we're asking whether targeted metabolic support could influence a disease-related biological process. Now, in psychiatry, this becomes relevant when we consider pathways related to neurotransmitter synthesis, inflammation, mitochondrial function, and stress physiology. The clinical goal is not to replace standard psychiatric treatment, but to reduce the biological strain, what we call the allostatic load, so patients can respond more effectively to broader treatment strategies. So to understand why nutraceuticals might clinically matter, it helps to think through this biopsychosocial model, how external experiences become biological changes inside the body. One classic illustration comes from the early baby Monica observations described by Engel, where researchers noted that an infant's psychological state, comfort versus distress, directly altered gastric secretions. It was an early demonstration that psychological states can rapidly influence biological physiology. Now, over time, repeated stress activates the autonomic nervous system and the HPA axis, and that produces what we call the allostatic load. The cumulative wear and tear that disrupts the body's internal metabolic balance. So from a treatment perspective, this is where biological interventions can play a role, because nutraceuticals can sometimes help reduce that biological burden, which allows the patient to engage more effectively with psychological and social interventions. So a simple way to think about this is biological stability supports the psychological work. And when the brain's physiology is better regulated, then the therapeutic process is said to become more effective. Now, once we move from theory into clinical practice, safety has to become the first priority. Now, one of the most important safety issues with nutraceuticals involves pharmacokinetic interactions, especially through the CYP450 enzyme system. Now, many herbal products can either induce or inhibit the CYP450 enzyme, which changes how prescription medications are metabolized. For example, St. John's wort is a potent 3A4 inducer. Now, this can significantly reduce the effectiveness of medications such as oral contraceptives, warfarin, antiretrovirals, and several psychotropic meds because it's inducing the pathway. It burns it faster. On the other hand, agents say that are inhibitors like kava, for example, well, that inhibits several CYP enzymes and has been associated with significant hepatotoxicity because the drugs are not clearing fast enough. This raises the concern, especially when you combine these medications with others that are metabolized in the liver. Other supplements can have more subtle but still clinically significant effects. Ginkgo, for example, increases bleeding risk when combined with anticoagulants. Valerian can produce additive sedation with benzodiazepines or alcohol. And milk thistle may alter hepatic metabolism of drugs with very narrow therapeutic windows. So the key is that nutraceuticals should always be evaluated the same way you evaluate medications, by considering metabolic pathways, drug interactions, and the safety profile. The second major safety consideration is with nutraceuticals and the pharmacodynamics, meaning how these substances affect the body's physiologic systems and how those effects combine with psychiatric medications. Now, one of the most important risks is serotonin syndrome. Supplements such as 5-HTP or tryptophan can increase serotonergic activity, and when they're combined with SSRIs, SNRIs, and MAOIs, they can potentiate and push serotonin signaling to dangerous levels. Another major issue is sedation and CNS depression. Now, herbal products like valerian and kava, they produce additive sedative effects when combined with benzodiazepines, opioids, alcohol, CNS depressants, and we also have to consider bleeding risk. Agents such as ginkgo biloba and high-dose omega-3 fatty acids can potentiate anticoagulants as well as antiplatelet medications, and supplements carry organ-specific risks. For example, kava has been associated with hepatotoxicity, particularly in patients with underlying liver disease. One final thing are the stimulatory products such as bitter orange, which contain synephrine. Now, these may increase heart rate and blood pressure and should be used very cautiously in people with cardiovascular disease. One rule you can follow is to stop herbal supplements 1 to 2 weeks before surgery because of increased risk of bleeding and sedation. So this slide outlines a simple clinical framework for deciding when nutraceutical use is appropriate in psychiatric practice. And the key distinction here is to know the difference between repletion and supplementation, which are often interchangeably used. So the first step is to suspect that there's something and then ask about it. Now, many psych symptoms like fatigue and cognitive fog and low mood, and low food can cause low mood, and can overlap with nutritional deficiencies, and low food will lead to nutritional deficiencies. So it's important to screen for dietary patterns such as vegan or highly restrictive diets, and review their medications and look for risk factors like GI surgery, alcohol use, malabsorption disorders, and now everyone's on a GLP-1 and they don't feel like eating, so they're not eating. The second is to test and assess. Now, in clinical practice, we want to follow the principle test before you treat. And that typically means ordering things like B12 folate or methylmalonic acid and homocysteine or vitamin D or iron panels. And depending on the presentation, the goal is to determine whether the patient truly has deficiencies or simply levels that are suboptimal but still within range. And the final step is to do something about it, and this is where repletion versus supplementation distinction matters most. So repletion refers to using higher therapeutic doses for a limited period of time to correct a confirmed deficiency, Whereas supplementation, on the other hand, refers to maintenance dosing aimed at supporting normal physiologic levels while staying below established upper limit intakes. Now, we do have to monitor when you do this. So after initiating a treatment, labs should typically be rechecked at about 8 to 12 weeks, symptoms reassessed, and the dose either reduced, maintained, or discontinued. You want to avoid blind supplementation because it wastes resources and may expose the patient to any unnecessary toxicity. And remember to document specific clinical indication for treatment. For example, vitamin D repletion for a level of 18, rather than just simply recommending supplements for general health. Now we have to be careful here with the fat-soluble vitamins, and they are A, D, E, and K, and their deficiency profiles, particularly when it comes to psychiatric practice. Now, one thing to keep in mind is that deficiencies in these vitamins often occur in conditions that impair fat absorption, like malnutrition, GI disease, alcoholism, certain surgeries. Let's start with vitamin A. So this deficiency can present with irritability, depression, and mood instability, although classic medical findings involve night blindness and skin keratinization. Now, in practice, we usually see patients with severe malnutrition or fat malabsorption syndromes, which means you'll also have other fat-soluble vitamin deficiencies. So another one would be like vitamin D, which is the most relevant because low levels are associated with depression and fatigue and cognitive complaints. And medically, you'll see things like osteomalacia in adults or rickets in children, along with muscle weakness. Now, the risk factors include limited sun exposure, which is everybody north of Atlanta in the wintertime, obesity, older age, darker skin. All of that reduces vitamin D synthesis in the skin, so we may supplement. Vitamin E deficiency, less common but can lead to neurological symptoms, including things like neuropathy, ataxia, mild cognitive impairment. And from a medical standpoint, it can also cause hemolytic anemia and muscle weakness, particularly in patients with severe fat malabsorption. Finally, vitamin K deficiencies does not typically produce a primary psychiatric symptom. The main manifestation with a vitamin K deficiency is impaired clotting, which leads to things like easy bruising or prolonged bleeding. And that can occur with things like prolonged antibiotic use, which disrupts the gut flora, or in conditions that impair fat absorption, like, say, cystic fibrosis or pancreatic insufficiency. Now, the key clinical takeaway is that vitamin D has the strongest evidence base for psych relevance, particularly in mood disorders and seasonal affective patterns. But all fat-soluble vitamin deficiencies should be considered when a patient presents with unexplained neurological symptoms that are systemic. Now, we spent a lot of time talking about the deficiencies, but we can't overlook the toxicities because in America and in our modern first world, anything worth doing is worth overdoing. And so if you overdo the fat-soluble vitamins, they get stored in body tissue and accumulate, and you can become toxic. Now, vitamin A toxicity can present as nausea, liver injury, headache, and skin changes. And importantly to note, it can cause teratogenicity in developing fetuses. So this can cause some serious problems with very high dose vitamin A supplementation. So it should be avoided during pregnancy unless it's medically indicated, that is for a deficiency, and monitored carefully. Vitamin D toxicity usually occurs with really high doses taken chronically, and the primary concern is hypercalcemia, which can lead to kidney stones and confusion and cardiac issues. So when you use therapeutic vitamin D, you need to monitor the 25-OH-D level and calcium. And also, vitamin E can cause problems at high doses, specifically increased risk of bleeding, and it interferes with vitamin K-dependent clotting pathways. Some studies have suggested a possible association with hemorrhagic stroke with high E supplementation at very high doses. Finally, vitamin K itself is not typically toxic, but it has an important drug interaction, and that is with anticoagulants such as warfarin. Now, the key issue here is consistency. So any sudden change in a vitamin K intake can destabilize anticoagulation control. So if you are on a high dark green leafy vegetable diet normally, the Coumadin dose can be adjusted to meet that. We wouldn't tell you to swear them off. We'll say just do what you're normally doing. Don't change it too abruptly, and then we'll dose accordingly. The main thing to keep in mind with these fat solubles is more is not better. And you always want to try to get nutrients from dietary sources first because they absorb better. And just know that high dose supplementation with the fat solubles can lead to toxicity due to tissue accumulation risk over time. Now, let's talk about the water-soluble vitamins, especially the B vitamins, which are highly relevant to psych practice, and they play a key role in energy metabolism, neurotransmitter synthesis, and neurological function. Now, most people are more cavalier with these because we say, you just pee them out. Let's talk about that. So vitamin B1 or thiamine deficiency is classically associated with irritability, confusion, and memory impairment, and we most commonly pay attention to this in Wernicke's-Korsakoff syndrome, in which it's the most commonly associated with alcohol use disorder. But it can also occur in malnutrition after, say, bariatric surgery. Vitamin B3 niacin, this deficiency causes pellagra. This is also used in doses to treat hypertriglyceridemia. And you can remember vitamin B3 with the 3 Ds. B3 deficiency, pellagra symptoms, dermatitis, diarrhea, dementia. So then if you supplement it, these problems should reverse. Now, psych symptoms can also include things like depression, anxiety, or even psychosis, particularly in severely deficient states. Vitamin B6, pyridoxine, this is involved in neurotransmitter synthesis. This is also given alongside INH to prevent optic neuropathy on someone taking isoniazid. This also is involved in the serotonin and GABA synthesis. So deficiency can present with depression, irritability, and confusion. And medically, you might see a microcytic anemia or a seborrheic dermatitis with this. Now, this is interesting because I see a lot of my patients with schizophrenia develop this seborrheic dermatitis, so it might just be worth supplementing. The INH is because of the B6 metabolism. The isoniazid therapy interferes with it, with the being able to absorb and use it. Folic acid and vitamin B9 deficiency is strongly associated with depressive symptoms and cognitive decline, and medically you might see something like a megaloblastic anemia, that is the MCV greater than 100, and it can also contribute to neural tube defects in pregnancy, which is why folate supplementation is standard in prenatal care. Now, you need to be saturated pre-conception. Now, risk factors include things like malabsorption, alcoholism, certain genetic polymorphisms, specifically methyl tetrahydrofolate reductase variants, and we've talked about that in the pharmacogenomic testing. B12 or cobalamin, this is particularly important in psychiatry because deficiency can produce symptoms like depression, psychosis, or even mania, along with neurological findings like ataxias and paresthesias. The common risk factor for these B vitamin deficiencies are vegan diets or lacking intrinsic factor leading to pernicious anemia or gastric bypass surgery. Now, the big one also, the main one we need to talk about is vitamin C deficiency. This is pretty uncommon, but it can lead to fatigue and depression and irritability. The classic medical finding is scurvy, so bleeding gums, poor wound healing. And this can occur in very restrictive diets or heavy smokers who have a higher vitamin C requirement. Now, a key clinical takeaway is that water-soluble vitamin deficiencies often will produce neuropsychiatric symptoms before the classic medical signs appear, such as anemia. So for that reason, a low index of suspicion for screening a high-risk population is warranted. So now we're going to move from deficiency to clinical utility. So like how these vitamins actually show up in day-to-day practice. Let's look at vitamin B6, B9, and B12. Now these are the central neurotransmitter synthesis and methylation pathways. And these pathways influence the production of things like serotonin and dopamine and norepinephrine. Because of that, deficiencies in these vitamins can directly affect mood, cognition, and emotional regulation. One clinically important example is L-methylfolate. Now, this is the biologically active form of folate, which has evidence as an adjunctive treatment in major depressive disorders, especially in patients who have not responded fully to SSRIs. Next is thiamine or B1, and in psychiatric practice, this is important because people with alcohol use disorder and severe malnutrition, thiamine deficiency, we have Wernicke's encephalopathy. So for that reason, thiamine repletion is often given proactively in high-risk patients. Vitamin C is less central to neurotransmitter synthesis, but relevant. It has antioxidant properties, which may help reduce oxidative stress, and that's been implicated in things like anxiety and mood disorder. So the evidence is modest, but it illustrates how broad of a role nutrition is playing in mental health. There are a couple of important safety considerations. So high-dose B6, typically above 100 milligrams a day, can actually cause symptoms of peripheral neuropathy if used chronically. High levels of folate, well, they can mask B12 deficiencies, which may allow neurological damage from B12 deficiency to progress unnoticed. So if you're going to give the folate, supplement the B12 with it. So the key takeaway really is water-soluble vitamins are often thought of as benign, but you should still think about them carefully and dose them and monitor them and use your clinical judgment. This slide introduces the concept of one-carbon metabolism. Now, this is a biochemical pathway that plays a central role in methylation and neurotransmitter synthesis. This pathway is particularly relevant in psychiatry because disruptions in it can affect the production of key monoamines like serotonin, dopamine, and norepinephrine. One of the most commonly discussed is the MTHFR enzyme, which functions as a metabolic bottleneck. Certain genetic variants, most commonly C677T polymorphisms, they reduce the enzyme's ability to convert dietary folate into the active form L-methylfolate. When that conversion is impaired, the downstream methylation process that supports the neurotransmitter production may also be reduced. So the pathway also depends on several B vitamin cofactors, especially folate and B12 and B6. These vitamins help regulate levels of homocysteine, which is a metabolite that becomes neurotoxic when elevated. So when functioning properly, this system supports normal monoamine synthesis and neuronal health. Another molecule that emerges from this pathway is the S-adenosylmethionine, or SAMe. SAMe is often referred to as the universal methyl donor, and it plays a role directly in the synthesis of neurotransmitters such as serotonin, dopamine, and norepinephrine. This pathway helps explain why L-methylfolate, or SAMe, might sometimes be used adjunctively in treatments of depression, especially in patients who have not fully responded to standard antidepressant therapy. And some patients reluctant to start medication may be willing to just do L-methylfolate and SAMe, which are both over-the-counter and readily available. This slide's about L-methylfolate, which is one of the most clinically relevant nutraceutical adjuncts. So the mechanism of action. So dietary folate and folic acid must normally be converted through several enzymatic steps before becoming L-methylfolate, the biologically active form, and that's the one that can cross the blood-brain barrier. One of the key enzymes is the MTHFR, and in patients with variants such as C677T, this step becomes inefficient. And then when you administer the L-methylfolate directly, that is in the form of these medications here, you bypass that bottleneck. So the active compound readily now crosses the blood-brain barrier and can support the tetrahydrobiopyridine, or BH4, which is an essential cofactor for the synthesis of serotonin, dopamine, and norepinephrine. On the right side here, you'll see that the slide about the evidence, most notably in randomized trials. So in 2012, in the Journal of Psychiatry, these studies evaluated L-methylfolate as an adjunct to SSRIs in treatment-resistant depression. And the key finding was that at 15 milligrams a day, this produced significantly higher responses and remission rates compared to placebo. Interestingly, the lower 7.5 milligram did not separate from placebo, which is why the higher dose is considered the therapeutic range. Now, in terms of dosing, the typical strategy is to start augmentation at 15 milligrams daily, with onset effect appearing in about 2 to 4 weeks. Now, some clinicians use 7.5 to 15 milligrams in other contexts, such as cognitive symptoms or adjunctive treatments in schizophrenia, though the evidence is more limited. The bigger takeaway is that L-methylfolate is not simply a vitamin supplement. In psychiatry, it functions like a metabolic cofactor that supports monoamine synthesis, which is why it can be a useful adjunct to the partial responders in antidepressant therapy. Well, magnesium's all the rage. So beyond vitamins and minerals, the minerals also play an important role in psychiatric function. So specifically magnesium and zinc. Now magnesium, this mineral participates in hundreds of enzymatic reactions and is important for neuromuscular stability and NMDA receptor regulation. Now clinically, magnesium supplementation is often used to reduce anxiety, improve sleep quality, and it serves as an adjunct in depression treatment. When you recommend magnesium, the formulation matters. So magnesium glycinate or magnesium citrate are preferred because they tend to have better absorption and better GI tolerance compared to the other forms. There are also important safety considerations. Patients with renal impairment may have difficulty excreting magnesium, and that increases the risk of accumulation and toxicity. Additionally, higher doses, say above 350 milligrams daily, can cause diarrhea and sometimes hypotension. So dosing should be thoughtful. I mean, mag oxide comes in 400, and that's a standard dose, and they'll do that twice a day if they're repleting. The second mineral here is zinc, which has been increasingly studied in psychiatry because of its role in neuroplasticity and brain-derived neurotrophic factor, BDNF. Several studies suggest that zinc may provide adjunctive benefit in depression treatment, particularly when combined with antidepressants. Now, the dose is important, 15 to 30 milligrams daily, taken with food to reduce GI irritation. With long-term zinc supplementation, zinc competes with copper for intestinal absorption. So, chronic high-dose zinc can eventually lead to copper deficiency. So patients taking zinc long term, you need to be mindful and monitor when appropriate, and then be mindful of copper deficiency symptoms, which happen to coincide with neuropathy symptoms. So pay attention to that.
Can lead to hypercalcemia and kidney stones. And clinically, this may present with things like constipation, abdominal pain, confusion, and the classic mnemonic sometimes sounds like stones, bones, and psychiatric overtones. Now remember, most of our psychotropic meds can also cause constipation, so you have to be careful with the supplementation as well as the co-use of psychopharmacology. Another consideration is that calcium can interfere with absorption of things like iron and zinc, and so that may be setting the stage for another deficiency that could be worth noting. And in some studies, it's even been associated with cardiovascular risk. The other one here is magnesium. Now, while magnesium is often therapeutically useful, excessive levels can lead to things like hypotension, bradycardia, and arrhythmias, especially in patients where renal impairment is involved, and the body can't effectively clear this. It can also, in higher doses, lead to things like diarrhea, which can exacerbate dehydration, which can worsen orthostatic hypotension. So pay attention. Iron is another mineral where caution is essential because excess iron leads to systemic overload and iron toxicity, and also constipation and clotting and abdominal pain, and can, in serious cases, lead to organ failure and can be fatal in children. So you don't want to over-supplement things like that. Zinc, when taken in high doses, can suppress the immune system, and it can also induce a copper deficiency by competing for absorption in the gut. Now, this can eventually lead to anemia and neutropenia, so worth noting there. And then selenium toxicity, sometimes called selenosis, that can present with hair loss and brittle nails and gastrointestinal upset and a characteristic garlic-like breath odor. So the key issue with selenium is that therapeutic index is quite narrow, and toxicity can happen at relatively modest doses, but it's all the rage on instant social media. It's better to get it in a food source. It's hard to eat a lot of Brazil. Finally, the other one here is iodine excess, and I mentioned CMOS as being also popular. Well, you have to be careful. The iodine might be in the CMOS. So high iodine intake may trigger autoimmune thyroiditis, such as Hashimoto's, or it can lead to thyrotoxicosis, both of which can produce psychiatric symptoms, including mood instability and anxiety. So the clinical takeaway here is that minerals do not follow a more is better curve, and they have a therapeutic window that's often narrow, so you should be aware and assess for dietary intake and confirm the clinical indication before you recommend a supplement. Now, before we finish this section, I want to briefly introduce the category of medical foods in neuropsychiatry. Now, these are not simply supplements. These are under FDA definitions. Medical foods are formulated to manage a specific disease or a metabolic abnormality and are intended to be used under supervision. One of the first examples of a medical food would be something like L-methylfolate, commonly known by the brand name Deplin. This is the biologically active form of folate, and its clinical relevance lies in the MTHFR pathway. Now, some individuals have genetic polymorphisms that reduce their ability to convert folic acid into the active methylfolate. So by providing the active form directly, L-methylfolate bypasses that metabolic bottleneck and crosses the blood-brain barrier efficiently. And clinically, we most often will see this used as an adjunctive treatment in depression, especially in patients who have only been partial responders to SSRIs or SNRIs. It's also been explored in schizophrenia, especially in cases where there's elevated homocysteine, which can contribute to metabolic or cognitive dysfunction. The other medical food that contains this is cerefolin, NAC. Now, this formulation is methyl B12, L-methylfolate, and N-acetylcysteine, all combined together. And the goal here is to address the metabolic contributors to cognitive impairment, particularly elevated homocysteine level and oxidative stress. That's the same NAC that they're giving for acetaminophen toxicity. The NAC component is what's providing this glutathione support, while the B vitamins, they facilitate the methylation pathways involved in the neuronal function. The third example is another one called Axona, and this contains a medium-chain triglyceride, specifically caprylic acid, C-A-P-R-Y-L-I-C, caprylic acid. And these compounds are metabolized into ketones, which help the brain, allows them to use energy substrates. Now, this approach is based on an observation that glucose metabolism becomes impaired in Alzheimer's disease. So ketones can potentially provide an alternative fuel source for neurons. The key takeaway here is that these products should be treated as targeted metabolic therapies, not as generic supplements when using them, and clinicians should document their medical rationale, such as hyperhomocystinemia or treatment-resistant depression. So you want to identify a specific symptom target, to establish a plan for monitoring and ongoing care. So another category frequently encountered is this in integrative psychiatry, and that is the adaptogens. This term refers to botanical compounds that are proposed to improve stress resilience and stabilize the physiologic processes associated, especially through something called modulation of the hypothalamic pituitary adrenal axis. Now, the basic idea is that these compounds help the body adapt to chronic stress, and theoretically they restore homeostasis rather than pushing physiology in one direction the way many pharmaceutical products do. There are several botanicals that are commonly discussed in this category, the most common of which is ashwagandha, probably the best known, and this is studied to reduce anxiety and cortisol in the process of that stress response. Rhodiola rosea is another one typically marketed for fatigue and burnout and stress-related exhaustion. Ginseng in particular, Panax ginseng, this is generally promoted for energy, cognitive performance, and general vitality. Now, when we look at the evidence base, the picture is mixed. There are some randomized controlled trials suggesting benefits for stress reduction and mild anxiety. But the literature is limited and the sample sizes are, small and heterogeneous. And there's also a lack of standardization in the herbal preparation used, and it's hard to know, are you getting the product that was in the study? Also, who funded the study matters a lot also. So that variability makes it really hard to compare studies or establish consistent dosing recommendations. There are also important safety considerations. Adaptogens should generally be avoided in pregnancy and lactation. We don't have robust safety data. So another issue is quality control. Unlike prescription medications, botanical products can vary substantially, and if they're fresh from the ground, well, variety is the only constant in nature. So between manufacturers and contamination and inconsistent active compounds, concentrations are real concerns. So the clinical takeaway is that adaptogens may have some supportive evidence for stress-related symptoms, but you need to approach these with caution and really critically appraise the product for quality and safety. Now, this slide reviews several herbal and agents that have some level of psychiatric evidence, but also importantly, some safety considerations to consider. So start with saffron, derived from the Crocus stadius. Now, several meta-analyses have suggested that saffron may have antidepressant effects comparable to SSRIs, such as fluoxetine, citalopram, in mild to moderate depressive disorders. Mechanistically, this appears to inhibit the reuptake of serotonin and norepinephrine and dopamine, so it works a little bit like, an SSRI and bupropion, although the exact pathway is still being studied. So in terms of safety, generally well tolerated, mild side effects such as nausea, dizziness, headache, but you need to use caution on people that are getting anticoagulants and individuals that may have bipolar disorder, because theoretically they could have an affective emergent delirium. This could flip them into hypomania if it's supposedly working along the same path. St. John's wort, this is also the most extensively studied herbal antidepressant. There is robust evidence supporting it for mild to moderate depression. It's widely prescribed in parts of Europe. However, the major issue is drug interaction. So this is an inducer of the 3A4 enzyme pathway, which can significantly reduce levels of medications such as oral contraceptives, antivirals, warfarin, cyclosporin, so if they're a transplant patient, be careful. It can also contribute to serotonin syndrome when combined with SSRIs or MAOIs. So it's critical to ask specifically about St. John's wort use, especially in women of childbearing age, because it can cause failure of contraceptives. Now, kava, widely studied, some implicated it to cause problems. There has been a Cochrane review suggesting some benefits for generalized anxiety disorder with efficacy compared to low-dose benzodiazepines. So the advantages, this may be less sedating at therapeutic doses. However, the major concern is hepatotoxicity. Now, I'm told what they studied was a lot stronger and not the stuff that's in the marketplace, but I don't know. So because of this, kava has been restricted and in some countries even banned. It can potentiate alcohol and other sedatives, and chronic use has been associated with a dermatologic condition called kava dermopathy. I've never seen it, but the literature tells me it. Finally, lavender, particularly the oral preparation of Selexin. This has evidence for supporting reductions in the Hamilton Anxiety Score, so that's clever that they used our standardized test. And lavender aromatherapy is sometimes used as an acute agitation or sleep support. Overall, generally considered safe, although patients may experience mild GI discomfort, and sometimes it's described as the lavender burps. There is also a possibility of sedation if combined with other central nervous system depressants. The key message here is that some herbal agents do have measurable psychiatric effects, but they should be approached with the same clinical scrutiny that you would apply to any pharmacologic treatment, especially regarding drug interactions and safety profiles. All right, so let's get very practical. These are the clinical questions. When should we stop an herbal supplement? At the same time, I'm asking when should we start or stop a psychotropic med? The first category that you would stop in is if you develop hepatic symptoms. If the patient gets jaundice, dark urine, upper right quadrant pain, or unexplained fatigue, well, herbal products should be stopped right away, and the liver function should be obtained, and it should include coax. This is particularly relevant with herbs that are known to have hepatotoxic potential, like kava, black hash, some multi-herb blends, where attribution can be difficult. The second warning sign is any new bleeding or bruising. If the patient gets bloody nose, epistaxis, bleeding gums, petechiae, unusual bruising, we should consider the herbal agent that affects platelet function or coagulation studies. Some examples include things like ginkgo and garlic and ginseng, high-dose omega-3s, anything over 3 grams a day. Another clinical scenario that we need to think about is serotonin syndrome. So herbs like St. John's wort have serotonergic activity when combined with other SSRIs and the like, and they may develop symptoms of agitation, diaphoresis, and clonus, or hyperreflexia. Those are the symptoms of serotonin syndrome, which should prompt discontinuation and evaluation. You also want to look for cardiovascular effects, especially if you're giving stimulant-type botanicals, agents such as bitter orange containing synephrine or yohimbe that can produce palpitations and hypertension and arrhythmias, especially in patients with underlying cardiovascular disease, which, by the way, yohimbe is also used for sexual enhancement performance. The problem is that sexual enhancement may be compromised due to cardiovascular disease, and this could make things worse, so we have to be mindful of that. From clinical management perspective, the first thing is in perioperative studies, herbal supplements should generally be held about 1 to 2 weeks before surgery to reduce the risk of bleeding and interactions with the anesthesia, especially things like ginkgo, ginseng, valerian, kava, etc. Routine screening is essential because most patients don't consider supplements to be medications, so a helpful question to ask at each visit is, have you started any new teas, powders, natural pills, medications, anything since our last visit? And the other thing is lab monitoring for certain herbs. So, for example, liver function tests when they use things like kava, black hash, INR, useful in patients who are on warfarin taking these products. And natural does not mean safe. Many of these compounds are biologically active and chemicals that can significantly alter the body metabolizing other medications as well. So let's talk about some of these amino acid compounds and core agents here. So these compounds generally do have some psychiatric uses. The agents typically will target things like neurotransmitter synthesis and inflammation and glutamatergic signaling. So let's look at GABA. You know GABA as the primary inhibitory neurotransmitter in the brain. So the theoretical rationale is straightforward. Supplementation should promote relaxation and anxiolysis. However, there is an important limitation. Oral GABA has a relatively poor blood-brain barrier penetration. So that really raises the question about how much central nervous system effect is this really producing. Typical dose ranges from about 100 to 750 milligrams a day. And the most common side effect is mild sedation and tingling at higher doses. The next one is 5-HTP, 5-hydroxytryptophan, and this compound is a direct precursor to serotonin, and it's used for symptoms like depression, anxiety, and insomnia. And typical dose ranges from 50 to 300 milligrams daily. The key safety issue here, of course, is serotonin syndrome, especially when combined. L-theanine is a popular amino acid found in green tea, and it's interesting because it appears to promote relaxation without sedation and may enhance attentional focus. Typical dose ranges from 100 to 400 mg a day, and it's generally considered very safe with rare reports of headache and no well-established drug interactions. So good for green tea. N-acetylcysteine, this has gained a lot of attention in psychiatry. It's supposed to influence glutamate regulation and oxidative stress pathways. There is emerging evidence that this could be used in supporting obsessive-compulsive disorder, bipolar disorder, substance use disorder, non-suicidal self-injurious behavior. Typical doses range from 600 to 2,400 milligrams. I do use this in my addiction population. The most common side effect is GI upset, including nausea and diarrhea. The other one that's very popular is omega-3 fatty acids, particularly formulations that are higher in EPA relative to DHA. And they have evidence supporting their use as an adjunctive treatment in things like depression, possibly ADHD. The typical dose is 1 to 3 grams a day. At higher doses, you have to watch out for the increased risk of bleeding and some report of fishy aftertaste. So, finally, 5-HTP versus tryptophan. So tryptophan requires conversion through the rate-limiting enzyme tryptophan hydroxylase to produce that serotonin. So 5-HTP bypasses that rate-limiting step, which makes it more potent, but also raises the risk of developing serotonin syndrome when combined or in high doses. So this slide reviews some common nutraceuticals commonly used for sleep support, along with some clinical evidence for considerations. Now, the most studied agent here is melatonin, typically used between 0.5 to 5 milligrams, although I've heard some people going up to 10. And melatonin works primarily by regulating the circadian rhythm, and that is why it has the strongest evidence for the conditions such as jet lag and delayed sleep phase syndrome and shift work sleep disorder. The effectiveness is for primary insomnia maintenance, meaning staying asleep through the night. That's normally what it's best for. Not one that's going to knock you out. It's once you're out, it'll keep you out. So the next is valerian root. So an herbal product, traditionally for insomnia, the evidence is mixed, with some studies suggesting some mild benefit. Mechanistically, valerian appears to modulate GABA signaling, which may produce mild sedative effects. But you need to be careful because when combined, you can get additive sedation effects with other medications, and it can also bump up your liver enzymes. Magnesium may also play a role in sleep regulation. This appears to influence NMDA and GABA receptor activity, which can promote relaxation. It's also a smooth muscle relaxant, right? And we're talking about things like magglycinate or citrate. But it's important because if you have renal impairment, it can build up, and if the dose is too high, you can get diarrhea. So that's something to keep in mind. This is useful when you want to contend with relaxation and alpha wave activity in the brain, which may help patients experience, like if you have racing thoughts and I can't sleep because my thoughts won't stop going, magnesium might be your preferred supplement of choice. It promotes calmness without sedation. On the right side of the slide here, you're going to notice some medical food formulations. Notice gabardone. This targets sleep-related metabolic pathways through compounds such as GABA, choline, and 5-HTP. And there's also Centra PM. This is marketed for sleep disturbance associated with depression. It supports serotonergic and cholinergic pathways. Finally, please note this red flag. Combining sedating nutraceuticals with other CNS depressants, it can be dangerous. So products like valerian and kava should not be combined with benzodiazepines, opioids, alcohol, because the additive sedative effect can cause severe respiratory depression, sedation, and the like. So just be mindful of that. No lecture on nutraceuticals and supplements would be complete without talking about the gut-brain axis, which has become an area of increasing research in psychiatry. The basic idea is that the intestinal microbiome communicates with the brain on several biological pathways. Now, one mechanism involves neurotransmitter production. Many gut bacteria participate in the metabolic pathways that influence compounds like serotonin and GABA and dopamine precursors. So another way is this involves immune modulation, where the gut microbiomes are influencing systemic inflammatory signaling, which can affect brain function. A third mechanism involves short-chain fatty acids, and these are metabolic byproducts produced by bacterial fermentation of dietary fiber. And some of these molecules can cross the blood-brain barrier and influence things like neuroinflammation and neuronal signaling. Because of these connections, researchers have investigated whether probiotics live and what they do, and how these microorganisms are able to restore balance, and how they might improve psychiatric symptoms. At this point, the evidence is for mood, anxiety disorders is kind of mixed. So one important issue is that probiotic effects appear to be highly strain-specific and dose-dependent. So it makes it really hard to make general recommendations. But you may hear the term psychobiotics, and this refers to probiotic strains specifically studied for psychiatric effects. And this field looks promising, but not yet robust enough for routine recommendation. Another category is the prebiotic, and these are the non-digestible fibers that feed the beneficial gut bacteria. So early research suggests that they may have some role in stress regulation and modulation of cortisol response, although this literature is still developing, and there are some safety considerations. In most healthy individuals, these are well tolerated, but in the immunocompromised, there is some potential risk. There are commercial probiotics widely available, and they vary from strain identity to viability to colony formating counts. That being said, you probably should store them in the refrigerator. Most people, too hot, they kill them off. So this issue of gut-brain access is rapidly developing. So I need to do a little myth busting here. Natural automatically means safe? No, it does not. On the left side, these are the two most common beliefs you will see in this world. The first myth is if it's sold at the pharmacy, the FDA must have tested it and like a drug. Well, many patients assume that supplements undergo the same regulatory scrutiny as prescription medication. In reality, that's not how this works. So the second myth is more is better. So patients sometimes assume that if a vitamin supplement is beneficial, then doubling the dose doubles the benefit. This belief can be particularly dangerous, especially when you're dealing with the fat-soluble vitamins over time. On the right side is the issue of clinical reality. So the dietary supplements do not require pre-market FDA approval for safety or efficacy. Manufacturers are responsible for ensuring the safety, but the product can reach the market without that same level of testing. As a result, potency and purity and consistency may vary greatly between batches and labels. The other thing to realize is toxicity is real with nutraceuticals. So for example, those fat-soluble vitamins, they accumulate in body tissue. Similarly, the mineral overload is a real factor. Iron, selenium can cause significant organ damage. From a clinical perspective, two strategies are helpful. First, quality assurance. Patients should look for a supplement that carries an independent verification seal, USP, NSF, Consumer Lab, which help confirm that the product actually contains what the label claims. Second, adopt a test, don't guess approach. When supplements are used therapeutically, you should verify the indication and monitor appropriately. Lab values are helpful if we have lab values to test, for example, vitamin D, B12, liver enzymes, etc. The goal is not to dismiss the supplement entirely, but to help patients understand that these are biologically active compounds that require the same thoughtful clinical oversight as any other treatment. Okay, let's shift our focus now to how we apply nutraceutical evidence across different populations, because this means we need to consider things like pharmacokinetics and pharmacodynamic differences across the lifespan, including how metabolism and drug clearance change from pediatrics to geriatrics. And we also have to consider reproductive status, particularly in times of pregnancy and lactation, where the safety data of supplements is very limited. And we also have to consider how do comorbid medical conditions and overall polypharmacy burden influence whether a nutraceutical is appropriate for the patient. So when we consider nutraceuticals in pediatrics and adolescent populations, pharmacokinetics become particularly important. Children have higher total body water and immature hepatic enzyme systems. So this can create significant variability in drug and supplement levels because weight-based dosing now becomes even more critical to reduce the risk of toxicity and unintended effects. Looking specifically at things like ADHD, the evidence for nutraceuticals is modest but worth understanding. So there are some meta-analysis that suggest that omega-3 fatty acids with higher EPA content rather than DHA alone may provide small improvements in attention and behavioral symptoms. However, clinicians need to be cautious because products marketed as natural stimulants, for example, like bitter orange, contain some pathomimetic compounds that are associated with cardiac risk. So it should generally be avoided. And finally, you need to remember that pediatric safety data for many supplements is limited. Adult data is generally extrapolated onto kids, and it shouldn't be. We shouldn't be treating them like little adults. They're different. So every caregiver's supervision of administration and selecting the right product with the right certification, USP or NSF, when possible, and choosing liquid or chewable formulations that are easier and safer for kids to take as well. Now, when we think about nutraceutical use in reproductive age women, several clinically important factors come out. So first, in PMDD management, SSRIs such as fluoxetine, sertraline, they remain the first-line treatment. However, vitamin B6, pyridoxine, about 100 milligrams a day can help with the irritability and bloating that some patients may complain about. It's also important to note that higher doses can be harmful, so you don't want to go over 200 milligrams a day because that increases the risk of peripheral neuropathy. So supplementation should remain within safe limits. Second is folic acid status. So it's critical in preconception planning for most patients that the standard dose is 0.4 to 0.8 milligrams a day. The prescription is 1 milligram a day. In patients that are at high risk, such as those on, say, valproic acid or other anticonvulsants, because we're trying to prevent neural tube defects. Some people can go up to 4 or 5 milligrams a day, beginning at least 1 month before conception. So you also need to watch out for drug supplementation interactions, specifically St. John's wort, as we've said before, because that reduces the effectiveness of oral contraception. And finally, if they have the MTHFR polymorphism, that can impair the conversion of folic acid to its active form. They may require L-methylfolate supplementation, and the research is done at 15 milligrams per day. So that's worth paying attention to. Now, when we discuss nutraceuticals during pregnancy, the guiding principle is caution. Now, many supplements do lack that rigorous safety data in the pregnant population, so clinicians need to focus on clear evidence and know the safety profiles. And you want to avoid and exert caution, when you're prescribing things. Generally, we would avoid the sedatives like Hava and valerian because of CNS suppression and the effect it might have on the unborn child. High doses of vitamin A retinols, those are teratogenic, so you want to avoid those. You also want to avoid things like bitter orange and the stimulant products. They can increase the heart rate and impair placental perfusion. And, you should be cautious with any proprietary supplements or mysterious blends that are on the market. Some are generally considered safe, the one being L-methylfolate. Omega-3 fatty acids can be useful, and vitamin D supplementation in appropriate doses, if they're deficient, can be used pretty safely. Lamotrigine is the often preferred mood stabilizer when necessary. Valproic acid should generally be avoided, and lithium, depending on the trimester they're in, may pose teratogenic risk. But everything in psychiatry becomes a risk-benefit calculation. Now, during lactation, this is the clinical question, and that is, how do nutraceuticals come through the breast milk, and what effect might they have? So, in general, omega-3 fatty acids, particularly those with the EPA and DHA concentrations, generally considered low risk during breastfeeding, and they may support neural development in pregnancy. You want to prioritize pharmaceutical-grade, low-mercury sources. Also avoid the St. John's wort during lactation as well. You also want to avoid ginkgo biloba because it increases risk of bleeding, especially in the post-delivery period. Valerian can be sedating, so we don't want to sedate, and obviously we're not giving mom any benzos because they can lead to excessive sleepiness, poor feeding, impaired bonding, alter the sleep-wake cycle, which you're trying to regulate, both for mom and baby. Standard vitamin recommendations are fine, prenatal vitamins, and the like. So when we get to the geriatric population, the biggest clinical question here is the issue of polypharmacy combined with homeostenosis and reduced physiological reserve, right? They have reduced hepatic and renal clearance along with increased central nervous system sensitivity. So combinations in older adults makes them much more susceptible to medication-induced delirium and supplement toxicity than, say, the younger patients. The important safety thing to keep in mind is that the sedative herbs such as valerian and kava should never be combined with benzos or opioids because you can get increased falls, confusions, respiratory suppression. And you also want to be careful with anything that has a high-dose anticholinergic agent, and we tend to follow Beer's criteria. For insomnia in older adults, we like Ramelton and Survaxant, generally preferred over the sedative hypnotics, but CBTI still remains first-level intervention. Vitamin D and B12 fine, but appropriate dosing. Start low and go slow, and be mindful of fat-soluble toxicity. These highlight here the special populations where nutraceutical use will intersect with metabolism and organ function. So smoking significantly affects drug metabolism through the induction of the CYP1A2 pathway. And also polycyclic aromatic hydrocarbons in tobacco smoke, they increase enzymatic activity. So it's not really the nicotine that's driving it. So that's why when nicotine gum is applied in the hospital, when we don't serve cigarettes and we start antipsychotics, we don't get the same induction effect that happens as soon as they discharge. So as a result, serum levels can be reduced, things like clozapine, olanzapine, duloxetine. Smokers also metabolize caffeine faster, which means when someone stops smoking, caffeine levels can rise and cause jitteriness or toxicity. So if you're a cigarette and a coffee kind of person, your coffee may be too strong when you stop the coffee. Smoking cessation is a big deal also because of CYP1A2 induction. If it resolves quickly, if you've stabilized on medication, now that you've stopped, that dose can be much higher than necessary. Alcohol use disorder and chronic alcohol intake, this depletes key nutrients and inhibits absorption, especially things like thiamine. So Wernicke's-Korsakoff makes you at higher risk, especially if your alcohol intake is excessive. And we have to worry about hepatorenal impairment and the comorbidities of liver, kidney, and heart disease associated with alcohol. We also have to be careful in mixing high-dose niacin or black hash because of hepatotoxicity risk, especially when combined with alcohol. And in patients with celiac disease or after bariatric surgery, they may require sublingual vitamin formulations because they may have malabsorption. So that's another thing to keep in mind in that special population. So let me look furthermore about these comorbidities that can significantly alter how you contend with nutraceuticals. So in patients with HIV who are taking antiretroviral therapy, drug supplementation can destabilize treatment. Many antiretroviral regimens depend heavily on the CYP3A4 metabolism, so supplements that affect this pathway problematic, namely St. John's wort. That's an inducer of that pathway, which means you don't have sufficient antiviral levels, which means you may go from undetectable to suddenly detectable or resistant, and that's a problem. On the other hand, milk thistle can inhibit metabolism, which can increase the drug toxicity effect because the drug sticks around longer. And in patients with cardiac conditions, you need to be careful with the stimulant-like properties of bitter orange and phenephrine and the like, because it can prolong the QT interval, which sets you up for an arrhythmia to develop. High-dose omega-3s can also have an antiplatelet effect, so anyone taking an antiplatelet agent, aspirin, Plavix, Piclet, you need to be careful combining omega-3 fatty acids. GI disorders such as celiac disease and those with bariatric surgery can have malabsorption, and so the traditional tablet may just continue to pass out, so liquid and dissolvable may be necessary as well. Well, what about things like DHEA, estrogen, and testosterone? Well, hormone supplements are also quite popular, and they act much more like endocrine therapies, and therefore you have to be very careful. DHEA, for example, is an adrenal hormone precursor, sometimes used for adrenal insufficiency, sometimes taken for chronic fatigue or mood support, but you do get adrenergic, androgenic side effects. So you have to watch out for things like they may develop acne, hair loss, because you have extra androgens. Basically, you're triggering puberty. So all the horrible things that happen in puberty, you have to be mindful of whenever you start manipulating the sex hormones. And some say it can trigger hypomania or mania. The dose needs to be quite high for that. Same with testosterone replacement. Estrogen and progesterone can be helpful in perimenopausal women for mood instability and sleep disturbance. Progestin in particular has a sedating effect that may improve sleep. However, these treatments generally require medical supervision, that's you, and discuss with OBGYN if you need further input or endocrine. Now, men with hypogonadism, testosterone replacement does improve depressive symptoms, low energy, and reduced motivation. Remember, the diagnosis of exclusion, so hopefully you've addressed that first. But therapy does require routine monitoring, especially if hematocrit. More is not better. And keep in mind, many are getting these to accessory clinics, Ageless Man, testosterone clinics, Low T, online. You have to be sure that the true monitoring is going on because those online pharmacies are making money in the dispensing not really in the monitoring. So we need to make sure that it's properly done, especially in the age of telehealth and fragmented care. So are there contraindications? Well, there are some hormone-sensitive cancers that need to be considered, breast and prostate, also thrombophilic diseases and pregnancy states that can arise. So this here is meant to give you an integration of nutraceuticals into what clinical care might look like. First thing is you might be using it for adjunctive strategies to improve medication adherence. So when supplements reduce the biological burden, such as metabolic strain, inflammation, or certain side effects, patients may generally feel better as a result of this, which enhances the therapeutic alliance and increases their willingness to stay consistent with therapy. We cannot deny the economic considerations. Some of these products as medical foods are quite expensive. Some are covered by insurance. Some have low evidence to support them. And so economics does play a major factor in adherence. And the question is, are they going to decide to take the medication over the nutraceutical or the nutraceutical over the medication? Or do they try to save money by doing it not the way it's prescribed? So all of those factors need to be considered. The goal is to empower patients to take a more active role in their care, not to dismiss their genuine concerns. So when you're counseling a patient, the first thing is to ask. Many patients use supplements but don't volunteer that information unless they're specifically asked. It's important to ask about all products, prescriptions, over-the-counter, herbal products, teas, hormones, other telehealth practices they're getting things from. And you want to ask about dose and brand and source and is it certified? Because you want to understand, why is the patient taking this product? Is it for mood, sleep, self-management, and are they mitigating symptoms that may rise to the level of a disorder that needs more serious attention? Second, you need to assess. Here's where you evaluate the evidence for the product, potential pharmacokinetics and pharmacodynamics, and AI helps with this quite a bit. Use something like open evidence or doximity. And patients with medical conditions and lab values, especially liver and kidney function. Third, you want to advise about evidence-based recommendations, suggest safer options when appropriate, and clearly warn that, we may not know all the unknown risks that may come with this, and so you can help set realistic expectations about potential benefits and harms. And you want to help the patient choose quality certified products and monitor the relevant labs. And think about deprescribing supplements just as you would deprescribe pharmaceuticals as well. So I'll close with a few key takeaways for integrating this into your practice. First, test before you treat. Rather than recommending supplements blindly, prioritize repletion of a documented deficiency first. Second, look at the evidence selection. Not all supplements have meaningful data behind them, and some of the agents with stronger psychiatric evidence, like L-methylfolate and omega-3 for depression and mood, and N-acetylcholine for certain compulsive disorders, those are better studies. There are some robust information for that. The other thing is ask about the patient's use of supplements, especially if they don't volunteer it. Simple questions such as what products are you taking, natural or otherwise, can uncover some clinically important drug-drug interactions. And pay attention for red flags, right? Natural does not automatically mean safe. Some supplements induce the CYP450 pathway, which can make meds essentially ineffective. That may be the reason for their non-responder, or what you may label treatment resistant. So you want to be mindful of that. Because, pharmacodynamic toxicity is real, as is serotonin syndrome. And always plan across the lifespan risk. Where they are now may not be where they started. Just because they've been stable for 15 years, it does not mean they're necessarily stable now, or you're not increasing risk. So if you're interested in exploring this further, here are some resources that you can look at. Stoll has a couple of chapters in his Psychopharm book as well, if you're interested in reading about that. There is an edited volume of evidence-based herbal and nutritional treatments for anxiety and psychiatric disorders that's available. They look at meta-analyses and the like. Other things, there are some online resources in the Journal for Nurse Practitioners and the Journal of the American Psychiatric Nurses Association. Sometimes we'll have guidance articles as to what is approved. And also Aiken, I believe, has a website you can look into as well. Carlack, the guy that wrote the interview book that we recommend. So I hope you have found this useful, and be well.